It's going to be Lessons Learned, a New Approach to Pandemic Risk. Your moderator for this session is Steve Sternberg, who is a senior reporter at U.S. News and World Report. Is Steve ready to come out yet? Okay, I'm done with my introductory comments, and apparently he's not ready. Here he comes. Very good. Thank you so much.
Thank you. Thank you very much. Good morning, everyone. Thanks to the organizers for putting together such a terrific meeting and for inviting me to moderate this keynote on a new approach to pandemic risk. It's an honor to be here. Please join me in welcoming our panelists. They're arriving now. To my right, we have His Excellency Jakaya Kikwete, who was the fourth president of the United Republic of Tanzania. To his right, we have Stanley Bergman, who is the CEO of Schein Incorporated, major health supply firm. And last, but I think who will speak first with me is Ambassador Ertharin Cousin. She is Executive Director of the United Nations Food Program. So Lord knows, with pandemics coming thick and fast, we need every tool in our toolbox. Months ago, when I was first invited to come and speak at this conference, Ebola and the botched global response to Ebola was the public health story of the day. The after-action reports were grim. The world was caught unprepared and slow to act. The result, 29,000 cases, 11,300 deaths. The World Bank estimated that the three countries most involved, Guinea, Liberia, and Sierra Leone, took a $2.2 billion economic hit in 2015 alone. And those are three countries that can ill afford that kind of money. It's worth noting that healthcare workers were among the hardest hit. Between January 2014 and April 2015, there were 815 confirmed or probable cases of Ebola among healthcare workers. They were 20 to 30 times more likely to get infected than others. More than 50% of those who were infected were nurses and nurses' aides. 66% died. That's 418 people who put their lives on their line, who were lost to their families and to the Ebola response. Why? Well, in part because they lack personal protective equipment or the knowledge to use it correctly. Now, we're here to talk about a public-private partnership, or hopefully many public-private partnerships that can remedy the situation, that can get the supply chain up and moving early. It's critical. And it's critical because Ebola isn't the only threat out there. By the time we were preparing to plan, meeting to plan this session, talk of Ebola had faded. I was peppering the participants with questions about Zika virus. MERS in the Middle East is now a healthcare associated infection. The Jeddah outbreak of 191 symptomatic patients in Jeddah, I think it was 40% were 40 of the patients were healthcare workers. And now Ebola is back. There's a vaccination program going on in West Africa now because cases are spreading. So we have a lot to discuss. I'm really excited to be able to participate in this discussion. And what I'd like to do is, I'm going to take my chair. I'd like to ask Ambassador Cousins, who's been involved in these sorts of responses many times, to talk a little bit about the dynamics of life on the ground in the middle of a pandemic and the necessity for a rapid response. Ambassador Cousins?
Well, thank you very much, and thank you for this opportunity to speak to you. I know as I sit here as the Executive Director of the World Food Program at a health conference, you say, what in the world does the World Food Program know about addressing pandemic challenges? Why in the world would the Executive Director for responsible for feeding 80 million people in 80 countries around the world have anything to do with these kinds of activities? Well, the reality of it is, in feeding people, what WFP has become over the last 52 years is the logistics backbone for the entire humanitarian support system. We are responsible for working with humanitarian workers regardless of the challenge to ensure that what is required to meet the needs of that challenge is delivered. That we operate the United Nations Humanitarian Air Service, which means that when the airline stopped running to Sierra Leone, Guinea, and Liberia, WFP transported 24,000 humanitarian workers, including health workers. We're also responsible for the emergency telecommunication systems. When you are working in areas that are undeveloped, and in Guinea, many areas that are in the forest even, you don't have access to internet. So we are responsible for putting up that emergency telecommunication system that allowed us to connect 115 different locations across the 3 countries. So when you think about having to create those kinds of backbone systems, what that tells you was that nothing was in place before the epidemic occurred, before the healthcare challenges occurred. And so WFP stepped into that void. And from a logistics standpoint, it was necessary that, first of all, we meet our core responsibility, and that was ensuring that we provide food to people who otherwise would have gone hungry. You think about the healthcare emergency, and you don't think of it as a food emergency, but in reality, if people can't go to the market because they can't touch each other, then they can't access food. If farmers can no longer work in their fields because they worked in groups to plant and to harvest, you're going to have a food availability crisis. So it required us to develop a system for supporting food distribution, first moving food into the country and then food distribution that did not and would not detrimentally affect those who were distributing the food or create even more contact points for those who were part of the affected populations. Secondly, creating the support systems, the warehouses that would allow for humanitarians to deliver to the last person, which means that we constructed about 30,000 square meters of different facilities across the 3 countries that allowed for the storage and distribution and ultimately the treatment of those who were in need. It meant that, as I noted, when the air services stopped running, we stood up the UN Humanitarian Air Service, both hard-wing planes and helicopters, because in many places, again, you're talking about locations that are remote, without airstrips. How do you get to the last person? It meant, in many cases, many times, doing that by helicopter. But what we were doing was ad hoc at best. We were not prepared. And you've seen all the after-action reports. And what we know is that it cost us more in lives, as you noted, in people infected, as well as in dollars to respond because of that lack of preparedness, which was the basis for the conversations that Stanley and I began, to how do we do this differently in the future? How do we learn the lessons from overcoming the Ebola crisis of the past as we look to when, not if, the next health crisis occurs?
Well, perhaps, Mr. Bergman, you can talk a little bit about your discussions, the genesis of these talks, and your thoughts going forward.
Sure, Steve. I'd like to connect the dots on 2 statements that I heard literally in the last half an hour. The first, Steve, was from you. The world was unprepared and slow to act. And second, the CEO of IBM said, ecosystem of people working together. And that's really why we're here today. Henry Schein, probably most people in the audience have not really heard of. We are the largest provider of products to office-based healthcare practitioners, to veterinarians in private practice, and to dentists. And for about a decade, over a decade, we have been talking about the importance of infection control as it relates to pandemics, and trying to get the right people in the room to speak. And the reason why my company, myself, participate in these panels is because somehow or another they connect the right people. So let me tell you a story. Davos, January of 2015. Ertharin, myself, former Secretary General Kofi Annan, and a couple of others, media people, I think The Economist editor, were on a panel at the World Economic Forum. And we were talking about pandemic, and I believe it was the beginnings of Ebola. And it was said, if only we could get the infection control products to these countries on time, we would save lives. And we said in this discussion that industry wants to help. And I turned to former Secretary Kofi Annan and said, you convene and we'll come. Industry wants to participate. Ertharin raised her hand and said, I'm there. And I had no clue that the World Food Program was involved in emergency response with respect to healthcare products. So we exchanged cards and we said we'd get together. The next day, in the afternoon, it was a Friday afternoon, and we were all tired. It was almost the end of the World Economic Forum. We were in a small discussion group, chaired by President Kim of the World Bank, Dr. Margaret Chan of the World Health Organization, a couple of industry players, and Ertharin. And what we agreed there, just on the spot, was to put a program together so we could get the top infection control products into an emergency area immediately. And yes, there are ways to get these products into these places, but the products are not ready. No one knows who's going to convene and send them. And in the end, lives are wasted. The response, particularly by the US administration in sending people to West Africa in response to Ebola, was terrific. But it was a few days too late. That's on the one side. On the other side, President Kikwete. President Kikwete was the president, I think, for almost a decade of Tanzania, a very effective president. But one of the areas that President Kikwete focused on was public-private partnerships. And so what happened is that in the oral care area, President Kikwete raised his hand. You know, oral care, there's a direct correlation between good oral care and good health care. President Kikwete, who we'd met through a public-private partnership, an NGO in his country, had heard that my company was involved in oral care. And he said, can you come and help refurbish and repair the one dental school in Tanzania? One dental school, I think 40 or 50 graduates a year, serving about 40 million, 42, 43 million people. 48 million people. So we've heard these things before, and we said, sure. But didn't know anything would happen. The next thing that happened, we sent some people over, and before we knew it, we were engaging with government in a public-private partnership to repair the dental school and create a whole oral care program for the citizens of Tanzania. So, you see, one can work with a multilateral setting, in a multilateral setting, because now today, we're well on the way to creating a virtual stockpile for the 62 most important products required to deal with infection control when we're called. And we can get the products on the ground, onto the ground right away. We put a program together with organizations like UPS, BD, Becton Dickinson, and the World Food Program. On the dental side, we put a program together involving probably 50 or more companies and the government of Tanzania. So through these panels, Steve, you can get people together who actually make things happen. And so I'm very pleased you called us here to Washington.
My pleasure. President Kikwete, you have something in common with George Washington. When your term was up, you said, I'm ready to move on to other things. Could you talk to us a little bit about the challenges that you see unfolding on such an immense continent as Africa, and how you see the public-private partnerships giving people in Africa and in other parts of the world really the tools they need to deal with these emergencies?
Well, thank you. First, let me say after the Ebola crisis, when it was ongoing, Secretary General Ban Ki-moon set up a panel, which I chaired, to look into how can the world prepare better and respond better to a future pandemic, taking the Ebola experience as the base for that. So we did our work. We came up with a number of recommendations. I think the report is ready now with the United Nations. But let me highlight some of we came up with about 27 recommendations. A number of observations came out with 27 recommendations. But let me mention about 3 or 4 of these. One is that in the case of Ebola, what became evident is that it is weak health systems that are to blame. Mm-hmm. Because the 3 countries, Guinea, Liberia, and Sierra Leone, are poor developing nations. They've been through crisis. Sierra Leone and Liberia through civil wars. Guinea had a lengthy period of a political crisis. So you are in a situation where there are no hospitals, very few hospitals, very few dispensaries. There are very few health professionals. Mm-hmm. Guinea, which is better off, had 1 doctor for 10,000 people. Here in the US, it's 252 for 100,000. Mm-hmm. Liberia had 0.2 for 10,000 people, and Sierra Leone 0.1 for 10,000 people. We had a field visit. We visited the hospitals, the dispensaries, a few of them, and well, they were short in the basics of services. No running water, no electricity. The medicines are not readily available. Many of the facilities were inadequate. So, and then you have this outbreak. The professionals are inexperienced. They handle these patients wearing blue jeans, and they get infected, as you just rightly mentioned, 800 of them. 6% of them died. This is one set. So, in our conclusions, we said, if we cannot help these poor countries have strong health systems, we will not be able to prevent future epidemics. And because diseases know no borders, what is happening in Liberia, that's why you had someone from the US die, someone from Spain dying, and many people getting infected. It's just like the case of the Zika virus now. That's one set of observations. The second which you observed is that in 1851, after the pandemic diseases in Europe, there was a meeting in Paris, the International Sanitary Conference, where they discussed ways of preventing cross-border transmission of diseases. At that time, they talked about cholera, plague, and yellow fever. But then, in 1892, they came up with international sanitary regulations, defining what countries are supposed to do. Of course, over time, these have been reviewed, upgraded, And in 1969, then there was the international health regulations, again defining what countries should do in the event of a pandemic disease. So in order to prevent it from going from one border to the next border. The WHO has 196 members. Only 1/3 are compliant. So when you have only 1/3 of the countries being compliant in the event of an outbreak, then the whole world is not safe. So to ensure public health, global health security, we must make countries compliant with the IHR. And the biggest victims here, or the biggest culprits here, are the poor developing countries. So in our recommendations, we said ways must be sought to assist these countries be compliant with at least with what they call the core capacities of the IHR. The third important observation we made was that global response was late and inadequate. Of course, the protocol has it that the WHO is the one that declares an epidemic, a global public health emergency of international concern. The first outbreak was in December 2013. FAI, the public health emergency of international concern, was declared on the 8th of August 2015. So in these almost 12 months, we have 11,000 people dying because of that, because it got to a point. But why did it happen? They got it wrong. The first assumption was that because it has been happening in the Congo, in Uganda, in South Sudan, and then it disappears on its own, this one also would come to pass. But the Ebola in the three countries did not have that behavior. It moved from the countryside into the urban areas, and there it was. So, but then, that's one thing. And it is only after you declare a fake, then that is when you have this robust global response. When that was done, then we had this whole involvement of the US, Britain, France, and many of them in the private sector and in the public sector coming in to fight the disease, and it was readily quickly controlled. And then we are in this situation where some have gotten. But what is the other significant thing is, which we discovered, was that the WHO itself, in its structure, is a normative institution and not an institution that is operational. So in the event of an outbreak, what the WHO simply says is declare a fake public health emergency of international concern. They don't have their own in-house capacity to be the first responders. So after they do that, then they expect everybody else will come in. Fortunately, the US cared about Liberia. The United Kingdom cared about Sierra Leone. And Guinea cared about France. France cared about Guinea. But if you have a country where there is nobody who cares about it, then it would have been much more disastrous. So we said, what is important now is you must review the structure of the WHO so that the WHO can build own in-house capacity for operational response. Of course, there have been measures within the WHO to create a program for emergency response. But our panel said we need a specific center for that with autonomous capacity to take action when there is a. The other thing which we also observed was that we should not wait until so many people have died before we take action. Every soul is important. So we said the protocol for response should be revisited so that whenever there is an outbreak, immediately there is a credible response, not necessarily a public health emergency of international concern, but there is credible response. And this is also, we said, must be looked into the way we look at it. So reform of the WHO in order to build its internal capacity for operational response should be did. The fourth thing, there are so many things, but let me talk about the last thing.
President Kikwete,
Yes.
can I ask you, that's a perfect segue into a discussion broadly about how to trigger this response. We had a global public health institution that was a little slow to react. We have a discussion today about trying to bring together private-public organizations to respond. What would, if I can take the moderator's prerogative here and just ask you all, perhaps let me ask Mr. Bergman first. So what triggers this public-private response? At what point, is there going to be a mechanism in place to say, okay, well, the World Health Organization doesn't think this is an emergency yet, but we do, and we'd like to do something?
Steve, there is no mechanism, unfortunately, in the world today that responds fast enough. The World Health Organization is not an operational organization. In fact, there's largely voluntary information provided. It's not required. And so they don't have the mechanism to respond. And yes, in practically every disaster, there is some connection to infection control. The President cited the Infection Control Covenant of 100 years ago, which is not adhered to. I think what we first need to recognize is that you can have failed states for economic reasons, you can have failed states for military reasons, but you can have failed states for health reasons. And I have to tell you, my company, myself, we've been looking around for partners for over 20 years. And we stumbled into the unlikely partner, the World Food Program, because they actually have the ability to get products to the places where you need to get the products. And I'm not referring to food per se. They do that, of course, too. I'm referring to basic products to clean your hands, which were not available in the 4 countries that were impacted by Ebola. They came later. But by the time they came, tens of thousands of people were dead. And there was no education program in place to educate the leaders of those countries as to what was needed. So at least we got something going here with the World Food Program. And I would like to suggest to those that are interested, companies, people in public policy, people in government, reach out to Ertharin. For whatever reason, I'm sorry, I'm going to fill your inbox, but you respond, she responds. It's a great convening place. If you're asking for something practical, there can be many, many conferences. And I don't want to be an alarmist. And I'm not a public health person, and I'm not a doctor. But pandemics are a little bit like a stack of wood, dry wood, with matches in the neighborhood. And if we don't deal with this, we could have real issues in the world today. And we have to recognize that these kinds of pandemics do not end with a passport or a visa. They cross countries. And it's enlightened self-interest for the Western world with the resources and for business to understand that we need to work in a multilateral setting, find people to help us get infection control products and public education programs to these poor countries pretty quickly.
Ambassador Cousins, let me just ask you to respond to that. I mean, you may get lots of calls from folks who want to volunteer to help. How do you handle those logistics and get? Please.
I appreciate it, and I thank you very much, Stanley. Let me say, first of all, and I am not here to apologize for the World Health Organization, but I think we should all recall that, as President Kikwete was saying, the World Health Organization is a member state UN organization that has 195 member states that serves as their governing body and makes the rules for how they operate. Some years ago, the global community decided that they did not want an operational World Health Organization because they did not want the international community operating in their member states. They wanted a normative organization. So the World Health Organization became what it is today, a normative organization. Now, with these increasing crises, as we've been discussing, there's been conversation post Ebola about what should the World Health Organization look like in the future. Some would suggest that you need a World Health Program, much like the World Food Program, that is operational. But others would suggest maybe what we need, and this is what WFP has been working with the World Health Organization to develop, is more operational capacity inside the World Health Organization, but a partnership between the World Food Program and the World Health Organization that allows us to serve as a logistical backbone for the World Health Organization, working at the request of and under the direction of the World Health Organization to supply the goods that are necessary, the support that is required to ensure that healthcare workers can provide the services that are necessary. But we, as an organization, learned some years ago, we, WFP, we don't have all the answers. We can't do this alone. We know that resolving the challenges of today requires bringing together multi-sectoral actors, particularly the private sector. There are tools inside the private sector, knowledge inside the private sector, that must be brought to respond to the responses to ensure effective and much more efficient responses that save lives in a timely manner. What Stanley's referring to is we have now signed a memorandum of understanding between 11 companies, including Henry Schein, Becton Dickinson, Cardinal Health, the CDC, as well as the University of Minnesota, UPS, the World Bank, the World Economic Forum, UNICEF, WHO, and WFP, and we invite others who have come together to develop a global supply network for pandemic preparedness and response. With the support of the World Health Organization and UNICEF and the private sector, we've already identified the 60 critical items that we need to track on a virtual supply chain to know where they are and how we can move them in a rapid manner in response to a health crisis. What we need is to ensure that we have access to as much information about what is available regarding these 60 items in the system at all times to ensure that when we need to access them, we can have as much lead time as possible so that we can use shipping channels when available to avoid the necessity for air transport, which is sometimes 10 times more, and in the Ebola response was in fact 30 times more expensive than sea transport. So we have begun to develop that backbone that will allow us to move differently as a global community, but it will not work without private sector participation and commitment to the recognition of what Stanley just said. This may seem like a problem someplace else. That's a problem for poor people in places where I'm never going to go. But germs don't know borders, and you can't build a wall high enough to keep them out. So it's in all of our best interest to ensure that we develop the tools that are necessary together to have the ability to respond appropriately.
Well, I would like to invite members of the audience to submit questions because...
Can I add something?
Absolutely. But as President Kikwete is talking, we have three panelists who have lots of interesting perspectives on this subject, and so please get your questions in.
Yeah, with regards to the private sector participation, of course, we looked at it in the panel. Of course, there is this philanthropic part of it, which the private sector can be part of the movement. But one thing that became evident is that this is a disease that was first discovered in 1976. And before the Liberia, Guinea, and Sierra Leone outbreak, there have been 24 outbreaks of the disease. But this one came at a time when the medicines are not there, and the vaccines are not there. So, and then we looked, we said, one of the things as a lesson for the future, we must do more in terms of research and development of drugs and vaccines. Of course, in the discussion, some say the pharmaceuticals, we are private, we are not very much interested because these are diseases of the poor, and they will not make enough money, and therefore why invest your money on research and develop drugs for diseases of the poor? Well, we said, fine, now let's look at it from a humanitarian. Then we came up with proposals. Of course, they may be outrageous, but we said, now let the WHO and sit down and discuss ways of establishing a fund to support the private sector in their research work and development of vaccines and medicine. Maybe that's an area where I think the public-private partnership is so critical now, so that we don't get taken by surprise in the event of another outbreak of another disease. That's what I would add.
Thank you. We do have a question from the audience, but I want to just ask one more, which is that post Ebola, we're now all hearing about Zika and what a threat it poses. And one of the interesting things about Zika virus is that it brings in this whole new category of logistical demands. It brings in mosquito control and mosquito eradication, and personal protection against mosquito bites and that kind of thing. Is it possible to bring in support on that level too? I mean, to begin to try and prepare for other types of outbreaks that aren't necessarily blood-borne or aerosol droplet-borne. I mean, bugs travel in lots of different ways. If I could just ask the panelists to respond.
Of course, in Africa, our biggest problem has been malaria, the number one killer disease. And of course, we were working through the support of the President Malaria Initiative, PMI, which started with President Bush and then continued with President Obama. There were 3 interventions. One has been using the more effective drug against the disease, because the parasites had developed resistance to the traditional drugs being used to treat malaria. So they came up with artemether-based combination therapy. And the second has been the use of insecticide-treated bed nets, where when mosquitoes land on the net, they die. And the third, of course, has been indoor residual spraying. So with regards to bed nets, that's where we developed public-private partnership. We worked with Sumitomo Chemicals of Japan. They built a huge bed net factory in Arusha. When President Bush visited Tanzania, he actually went and visited this factory. We were able to produce bed nets, which really, because of these 3 interventions, where the U.S. has been in the forefront in supporting it, 6 million lives have been saved in the last 15 years in Africa. And infection rates have come down by 50 to 60%. And death rates among children has come down declined by 71%. So I'm sure there are these examples of partnership between the public and private, which are models which can also be used in the case of the mosquitoes in Latin America that are causing the Zika.
Thank you, President Kikwete. Well, let me turn to some questions from the audience. We had a question up a moment ago and I guess I would turn this to President Kikwete as well. China is investing fairly heavily in Africa these days, and a questioner wanted to know whether China has been involved at all in the Ebola response.
Well, I think they are one of the countries that sent military there too, to help. Yes.
Okay.
Some, of course, they sent also personnel. Not as robust as the US or the UK and France did. At least there's been some contribution.
Okay.
So can I just,
Mr. Bergman?
Yeah, I don't want to address the answer directly, but I want to give you just an analogy. You mentioned to what is needed. You mentioned China. So during the SARS epidemic, there was a shortage of masks in China. We got a call from people in Hong Kong that wanted to help. And literally within 15 minutes, we'd identified the masks in China. The point here is infection control is so important in these pandemics. And if you get to them quickly, you end it. You got to make sure that the government officials understand what's involved. And there's a lot that's been written about China as to whether who knew, who should have known, and how fast they responded. I don't want to get into that. But I do want to emphasize that we need a methodology in the world, and we're on the way there for the first time in a long time, to identify the cleaning, so the basic stuff that's needed to stop a pandemic from even starting.
Let me just say, China did make financial contributions to all of the major organizations working on to address the pandemic response in all three countries. But as President Kikwete said, the three major players from a financial and support standpoint were the US, the UK, and France.
Interesting. Okay.
So, and on the question of finances that the president raised, the World Bank at the G7 in May will announce and launch a pandemic emergency financing facility, which is a tool that the global community has asked for to begin developing the mechanism where the resources can be invested for faster disposition than what we had with the response to Ebola.
We have a question about electronic medical records in Africa. Having traveled a little bit in Africa myself, I know the challenges that might pose, especially, given all sorts of infrastructure issues related to the accessibility of power and the like. But I would ask President Kikwete, could you respond to this? Is Africa ready for electronic medical records as part of healthcare reform and how they would fight epidemics?
Well, one of the big problems we have in Africa, Tanzania included, is keeping medical records. It's something during my time as president we've been working on it, and with the support of the Canadian government, we've been improving on it. So as to birth rate, people are born, they have no birth certificates, there are no records, But of course, given the levels of development and poverty the countries are, there are so many priorities, and people may not take the issue of keeping the records as a priority, because there are so many contending needs, very little resources that you have. But there is a great awareness now on keeping the records in order to allow it. So I cannot say in terms of readiness, definitely Africa needs it. But in terms of readiness now, building the requisite infrastructure in order to have a smooth functioning electronic medical records, definitely some countries may be able to do, maybe probably South Africa and several of the other developed, more advanced countries. The majority of our countries, the first thing is have the records. That's the first support. Yeah. And then after that, you move to the next record, to the next level, electronic records. But it's something that is important, is inadequate, available.
Mr. Bergman?
I would submit we need electronic medical records in the United States, where not every single doctor has it. Don't want to get into politics now, but we had ideas and never got it done. Having said that, I'm not sure if the electronic medical record is the priority. What's the priority is telemedicine in one way or another. The technology is remarkable. You can have telemedicine now on a cell phone, and the percentage of cell phones in Africa today is quite astounding. And so I think there are terrific ways in which to advance NCDs, and I'm talking about the other side of the house now, non-communicable diseases using cell phones, and even the communicable diseases. But the technology is there, and actually, it's the one area I think we are making progress.
If I can just add very quickly, and President Kikwete was kind not to say this, but I'll say it. Africa is a continent, not a country. And so we are talking about 52 different countries that are in different places in their development. And so some countries are going to come along faster than others with technology, just as they have done in agricultural production and education and every other factor that we measure. And so as we look across the continent, there are countries where there are opportunities to capture different technologies for around medical records. But what we need to also look to is, and I'm going back to the point that President Kikwete made, and that is registration systems. And that is one of the other projects that WFP is working on, is how do we develop database registration systems for the poorest people on the continent to ensure that we begin to know what services are being provided as well as what services are needed for those who otherwise would not have access.
I was wondering how you would know if you had someone treated for Ebola in one place who turned up with a viral respiratory illness in another place, and whether there was any way to sort of to track a medical history across episodes of care. I would assume not.
Well, and that's what we're working with a number of agencies right now to develop that kind of a system where we have the opportunity through either biometric registration or just simple numeric identification to support the variety of different interventions that any one individual receive from a host of different organizations, whether it's UN, NGO, or government-related organizations. We today do not share that information across our different systems, but we are now working to create the protocols that will allow for that sharing of information, as well as we've invested in the platform, again, as the logistics support. We see information as the next logistics platform that we have a responsibility for supporting for the international community, for the poorest people that we serve around the world.
Well, we all know what a challenge HIPAA poses for health record security. And I'm wondering how that might play out in a situation like this, where you're trying to keep track of medical histories and provide appropriate care.
We haven't even gotten there yet, but I can tell you the lawyers are busy thinking about it. There will be a lot of lawyers working on this. So any lawyers who you know who are interested in this area of work, we are very interested in talking to them, not just about HIPAA, but if I am providing support to a pregnant mother, how do I ensure that that information is not used against her by her government? If we are providing those records to the government, that's probably a very poor example, but I'm sure you can think about examples where it may not just be related to health, but any information that we are gathering, where are the privacy lines when we as public servants are collecting data and sharing that data across the different organizations.
You know, I'd like to come back to a question, and again, invite you all to ask some of your own. But I'd like to come back to a question I asked earlier because I'm still a little unclear on the answer. So assume the next emergency comes along, and it's one which poses a great threat of or a great demand for infection control material. How do you envision the response taking shape? What sort of triggers do you see as bringing these public-private organizations together to say, now we have to act?
So, we know now, we have an agreement, not a legal agreement, but we have an understanding amongst a number of key constituents on, as Ertharin mentioned, the 62 key products that we need. We now have an understanding of where to find them. I mean, in relatively reasonable supplies, quantities. We have UPS committed, and there are other transportation companies and airlines that we will bring in. I think today we'll be better off than we were at the beginning of Ebola. We're not there yet because this initiative's a year old. But I think we'll be much better positioned because the one thing we know for sure is that we can call the World Food Program to actually help us move the stuff.
Yeah.
And it's very interesting. There are a lot of companies in the world, a lot of businesses that want to help. And they call. But if you take the Haiti situation, it took literally 2 months to figure out how to get the stuff there in the first place. I think we're in a much better shape today. And the World Bank is also interested in this. It's enlightened self-interest.
Yeah.
Because they want to make sure the world's economies do well. And if you have a pandemic or you have some kind of infection outbreak, you have more failed states and more economic risk. So I think we've got a lot of interest now, more so than ever. And I'm quite optimistic that for the first time, we've really got a way to get products to impacted countries. And I was really very happy to hear that President Kikwete is involved in this area too, because I think President Kikwete has shown in a number of fora that he can actually get things done. So I'm quite optimistic.
Could you talk a little bit, we've talked a little bit about masks and personal protective equipment, but I think I'm curious, and I suspect some of the folks in the audience might be curious too. What are some of the other products that you're talking about? I mean, what sorts of things are necessary for responding to these kinds of outbreaks? Hypodermic needles and what
yes.
Yeah.
But the number one, bar none, is to clean your hands.
Yeah.
We can go through the whole medical, if it's this, if it's that. And the Zika virus is just the latest and is getting attention. But there are so many viruses, and even in Latin America, that we don't talk about. This one gets on TV because of the terrible, terrible, horrendous impact. But there are viruses that have been there for a long time that people don't care about. So at the end of the day, it's about infection control.
Well, it's worth mentioning that we have large populations of people who migrate around the globe for various reasons. I mean, we've been talking about Zika and the Olympics. There are concerns about Zika and the Hajj in the Middle East. We have MERS, which has gotten to be a major concern. So there is, covering these issues, it's sad to say, but there is never a dull moment. I mean, there's always something around the corner, and it's often a surprise.
And Zika gets our attention now because of the horrendous pictures you see. But we have to understand what's happening in the Middle East has resulted in over 60 million refugees.
Yeah.
It's the biggest refugee movement since the Second World War. And yes, we're focused on the failed states, the military, the economic, the financial maybe, but within such a big movement of population, the implications for the spreading of disease is huge.
It's huge. Well, we have just a couple of minutes left. Let me just ask.
I was just going to add, when you ask about products, and Stanley can give you the list of the 62 products, is everything from gloves to ambulances, which are things that we procured in the response to into the Ebola virus. But imagine a system where for the first time on all of these 62 items, where we had one place where the response communities could go to know what products were in warehouses or in routes, were available or out of stock. The rubber gloves, and I'm sure most of you in here know this, something between 80 and 90% of our rubber gloves are now manufactured in Malaysia. And so having one place where a product is located would, when you're responding to a challenge in West Africa, knowing where there are stocks and brokers and other locations around the world could shorten supply chains and support the kind of response that Stanley was just talking about, where you can have healthcare workers having the tools that they need to respond in a safer way. But you don't learn, and you shouldn't learn, we hope you shouldn't learn, by doing. You should, by responding to a particular outbreak. This is a system that has been a year under discussion, that's all. We started talking about this, as you said, in Davos. We got together, the teams came together, and we've had, since this year's Davos, a couple more companies come on board. And we now have an agreement to work together. We haven't built up the trust that is necessary. We need to do that. One of the things that is going to be required is that we have a practice, that we have so in mid-2017, all of the parties will work together on a simulation exercise to ensure that we not only have the right on paper, that we know in response to the question you just asked, what would trigger and how would we respond? How would the system work? And so with support from the World Bank, the community will come together in 2017 to support this simulation led by the World Health Organization.
Well, we will look forward to hearing about how that goes. It sounds like a great opportunity. We have just a few seconds left. President Kikwete, do you have a closing comment or remark?
What I can simply say is that the world has learned from what has happened with the Ebola crisis in West Africa. And it appears that there's a better understanding on how we can work together, public, private, and faith-based organization, private foundations working together in order to respond and prevent the next segment. Let's continue to work together.
Thank you very much, sir. And thank you all for coming today. It's been a great discussion. Thank you.
Very good. That's the end of the morning session here. I just want a quick reminder, don't forget that at 3:35 p.m. we will be reconvening in this room for a great session on putting the consumer first, what does consumer-driven coverage and care look like, and our final plenary speakers, including Representative Diane DeGette talking about the 21st Century Cures Act. So have a great day for all these concurrent sessions, and see you back here this afternoon.